Well, good morning, everybody. I am delighted to be here, and I'm happy that each of you have chosen to come here to spend the day with us. We have an absolutely outstanding group of faculty who have come from really every corner of the United States to help us learn a lot about lung diseases in infants and children, and also to think about what's next and how we're going to move forward to help solve currently unsolvable conundrums. Before we get into the meat of the day, I'd like to take a moment to introduce the Lucille Packard Chief Executive Officer, Paul King. Paul has recently come to us from University of Michigan. We're delighted to have him, and emblematic of the tremendously collaborative and highly synergistic relationship that the medical school and the hospital have together. Lucille Packard has played a critical role in sponsoring this conference and made a really substantial amount of resources available to us to be able to have a conference such as this that is no cost to all of its participants. We're starting the meeting today where we look like we have a strong audience, and I anticipate that it's going to get significantly stronger as the day goes on. Mr. King, if you'll grace us with a few words, we'd appreciate it. Thank you, sir.
Thank you, David. I'm pleased to be here, fresh from Detroit, Michigan. Actually, I was in Detroit over the weekend, and so I appreciated whoever was selecting the music today. That was a nice Motown moment, which was good. I've been here on the ground. This is, I think, the beginning of week number 7 for me, so it's been great to have joined this wonderful team here at Stanford. David was kind enough to share with me some of the history of this conference, this being the second, and how many of you were at the first? Okay, that looks like most of you, so I can't tell you anything you don't already know, which is good. But anyway, it was interesting to look at the history of this conference and looking back in terms of the celebration of the 50th anniversary of Dr. Northway's seminal paper in the New England Journal of Medicine back in 1967, which I'm told was sort of the launch of neonatology, or at least a part of it. So I was pleased to hear that Stanford played such a significant role in that. Today, with the benefit of some of the leading lights of neonatology, perinatal, and pulmonary medicine, that's all of you guys, by the way, the Symposium will focus on what's likely the next generation of lung medicine, how to better diagnose, prevent, and treat lung disease using next-generation tools and deep genotyping. It's fitting that, as David was saying, that Packard and Stanford have the opportunity to host this conference in the shadow of Dr. Northway's seminal description of infant lung disease in this medical school situated between the hospital and one of the world's great research universities. Dr. Northway, as all of you know, but I've recently learned, was a radiologist who actually made rounds on the wards, which was pretty great. And through that work, he developed insights into problems that was not completely understood by others. He moved beyond the traditional boundaries of his discipline to make great discoveries. And today in your conference, together with all of your colleagues, we're going to continue to push forward in the hope of ensuring that tomorrow's care is forever better than today's. This conference, as David also mentioned, is hosted by our Division of Pulmonary Medicine and is designed to accomplish those goals. We believe that discovery will drive new models of care and cure. We're pleased to be able to bring together so many thought leaders to consider infant child lung diseases, genetics, diagnostics, and tomorrow's care. I hope that today teaches much, prompts questions, and catalyzes lifelong collaborations. Once again, I'm thrilled to be here, and I'm sure you'll have a fascinating day full of discovery. Thank you very much.
Thank you, Paul. It's great to have a CEO that's so supportive and is so clearly recognizes the importance of the mission. Thank you. It's also my pleasure to have Dr. Mary Leonard, who's the chair of pediatrics at Stanford. Mary's been a tremendous supporter of the Division of Pulmonary Medicine and of the discovery process and of physician scientists in general. Dr. Leonard, I look forward to hearing what your thoughts are today.
Thank you, David. So I'm also the director of the Maternal and Child Health Research Institute, and I want to say how pleased we are to support this conference, in part because we've supported different investigators in this area. And I also want to thank David, who serves on the executive committee of the Research Institute and has been so important in much of the work we do around supporting physician scientists. So David, congratulations. I think this is an incredible conference. You have well over 200 people registered from more than 20 institutions. So I think that's incredible in terms of the reach that you have in this entire discipline. And I enjoyed the opportunity to go through your program in advance and learn more about the distinguished speakers. Obviously, we have so many people here doing great work, but I think it's a real testimony to the impact of this conference that you were able to bring so many of the thought leaders in the disciplines here. So I've learned that you have people here who are going to tell us about surfactant protein gene mutations, epigenetics and lung development. The lung is a sensory organ, so it's really an extraordinary combination of different speakers. The last thing I want to say is that today is David's birthday. I thought that we would all sing a round of happy birthday, but I decided that was best done after everybody enjoys the wine at the end of the day. All right, thank you.
And indeed, it is an auspicious day. Thank you, Mary. I thought that was going to go unnoticed. So as people are coming in, we're going to get ready to lead off the conference. I have a few introductory comments that I'd like to make, and I'd also like to point out that we really have tremendous good fortune in having Phil Sunshine here, who's going to lead the conference off, and Phil is going to really be able to help us understand where we came from, so that I think in the end we can have a better idea of where we're going. We are going to follow up some of Phil's comments with Dr. Larry Nogi, who is really one of the people that's brought genetics into neonatology, and one of the young stars from the University of Cincinnati, Cincinnati Children's, Andrew Swar, is going to share with us the genomic changes that are unfolding in the moments immediately prior to birth and thereafter on a cell-by-cell level in the lung. One of the major conundrums in neonatology is congenital diaphragmatic hernia, how to care for those children best and how to improve outcomes. I think many people in this room would agree that the needle has yet to be truly and definitively moved in that particular ailment. And we're going to hear about how it is that the development of the lung ensues so that the diaphragm is well preserved and functions well. And Dr. Blumenfeld is going to share with us some of the latest developments in fetal surgery. And Dr. John Kinsella from the University of Colorado is then going to share with us his insights on how best to care for kids with congenital diaphragmatic hernia immediately after parturition and how to keep them as well as possible in the nursery. One of the very perplexing areas of lung biology is interstitial lung disease. It means a whole cornucopia of different meanings to different folks. It comprises everything from bone marrow transplant-related lung disease to, honestly, the surfactant protein deficiencies that Dr. Nogi is going to speak of. And we're going to have the benefit of Kristen Kuo, who's going to talk about the fundamental biology of interstitial lung disease, and Gail Deutsch is going to help us really learn about what that looks like pathologically. And Lisa Young is going to share with us some clinical pearls and some ideas about what needs to happen moving forward relative to interstitial lung disease. And we're going to close the day by speaking of bronchopulmonary dysplasia, which has been mentioned already today, was described here 51 or so years ago by Dr. Bill Northway. Dr. Christina Elvira is going to speak about some of the key molecules relative to the vascular development of the lung that's driving pulmonary parenchymal development. Dr. Abman is going to share with us some pearls surrounding the vascular hypothesis of lung growth and what might be happening pre-delivery to sort of program the fetus to have difficulties relative to lung growth. And Dr. Mike Tracy is going to share with us his thoughts about what care needs to unfold for those children after they're born. I would posit that really all of these different areas are woven together when we think about surfactant. We're going to hear a little bit more about the story of surfactant. And really, ultimately, we have moved now from a clinical physiologic world into a genetic world that is really beginning to think how we can bring these genetic tools to bear not just on diagnostics, but also on therapeutics. Through the course of the day, people who've heard me talk have seen this slide before. We're going to try to test the hypotheses that by bringing disciplines that were previously thought to be separate together, we're going to learn something that's much more durable than considering those different disciplines separately. And we're going to talk about how we got here, because one of the things that we seem to miss most in today's fractured world is the idea of having context and being able to consider the narrative theme to how we got to exactly where we are. And we're going to consider how people like Larry Nogi were able to develop the hypotheses that led to a paper in New England Journal of Medicine in 1993 that really was a seminal paper relative to the genetics of neonatal lung disease. And then one thing that I think is important for us all to recognize is that our care at the bedside drives discovery, and these discoveries that we make at the bench or in the laboratory or in the dry laboratory actually drive care as well. I want to really mention Dr. Sir John Clements, who really made the initial discovery of surfactant in 1957. And I hope all of you have gotten coffee mugs. Have the mugs been distributed? And if you look on those mugs, you can see that it's actually got the headline or the masthead of the paper itself. And it's also got a figure taken from the paper that really was the first argument in favor of the hysterixis curve. But interestingly, while Dr. Clements made that seminal observation, there was some evidence in the literature that actually even preceded that. And Kurt von Nergard wrote about surfactant tension counteracting a baby's first breath. And that was written in 1929 in a German journal, and he indicated that it should, in fact, be studied further. Interestingly, also, Peter Gruenwald wrote in the American Journals of Obstetrics and Gynecology that surface tension resistance of neonatal lungs to aeration was really an issue in these early problems with birth. And Dr. Clements made the description in 1957, and it was approximately 33 years later that the FDA finally approved the use of surfactant protein for babies in the absence of any research protocol when it could simply be prescribed. And Dr. Clements said, it's a big, big thrill when you think you've made a discovery, found an idea that no one else has had. That's as good as it gets. And he also said very specifically that every time scientists are forced to look outside their disciplines, such cross-fertilization of minds can happen. The consequences are often unexpected and sometimes wonderful. To wit, Dr. Clements was working in a military warfare unit that was designated or designed to address the perils, the pulmonary perils of toxin gases that were inhaled. And yet, he found his way to surfactant biology. Another person that merits our collective thanks and attention is Mary Ellen Avery. She wrote a paper in 1959. You can see it illustrated on the right of that slide, Surface Properties in Relation to Atelectasis in Hyaline Membrane Disease. Here is the figure that was in that paper. And interestingly, you can see surface tension on the y-axis and the weight of these infants on the x-axis. And you can appreciate that the closed circles were of the infants that died. And you can appreciate, too, that they had relatively high surface tension. These were all infants that died of hyaline membrane disease. And the one open triangle that appears in that graph is of an infant of a diabetic mother, which we also now know suffer from delayed maturation of surfactant. Mary Ellen Avery was a giant in our field. She did wonderful work for a tremendous period of time. She was an absolute pioneer, especially for women. She was one of 4 women in her class at Johns Hopkins. She went on to be the chairman of pediatrics at McGill University and became the first female professor at Harvard Medical School. And I got the chance to get to know her later in her life, and she was as humble as she was accomplished. Pediatrics got a huge jolt in 1963 when the Kennedy baby succumbed to hyaline membrane disease. At the time, approximately 25,000 infants a year were dying from hyaline membrane disease. This is from the New York Times. The baby was born at a little bit over 2 kilos, was approximately 35 weeks, and JFK wasn't around that day because he was celebrating or being honored for the 20th anniversary of the PT-109 rescue. That left Jacqueline alone, and she took the kids out for an outing and was lifting them up into a carriage. And some think that kind of started her off on labor a little bit early. This was the only child that was born to a sitting president in the last 120 years. And after a 39-hour struggle, the baby passed on. Dr. Sunshine has a lot of insight and has spoken to many of the principals who were at that, tried to care for that baby in the nursery. But irrespective of what went on with that baby, sad as it was, it absolutely catalyzed really meaningful research in hyaline membrane disease and also in medical sciences in general. One of the strategies that people gave for that baby, and this was actually, as I understand it, was driven by the Kennedys themselves. They made a decision to, and Phil can check me on this, they made the decision to give greater than 1 atmospheric oxygen into an isolate at that time. That increased level of atmospheric oxygen was very difficult to exhale against, and the baby succumbed from really dramatically high levels of CO2. The attending physician certified to a diagnosis of prematurity in hyaline membrane disease, a lung disorder that takes about half of the 50,000 infants who contract it each year. That was from the New York Times. In 1967, as you heard Mr. King mention, Bill Northway wrote a seminal paper that we spoke about a good deal at our last conference that we had here a little over a year ago. And he described these 4 different periods or stages of lung disease and described he coined the term bronchopulmonary dysplasia, the result of pulmonary healing in infants with severe RDS who ordinarily do not survive from toxic effects of oxygen superimposed upon healing in infants with severe RDS or from the effects of pulmonary oxygen toxicity healing severe RDS, intermittent positive pressure, ventilation, and poor bronchial drainage secondary to endotracheal intubation. It's really notable, if you look at the masthead on this paper, that there is Dr. Northway, a radiologist, Dr. Roseanne, who I believe was a radiologist, and Dr. Porter was a pathologist. There's no pediatrician on this paper, and this is one of the great acts of selflessness that pediatricians undertook. Phil will tell you that there was a lot of controversy surrounding whether pediatricians should be on the paper or not because they merited it, but there was some concern about publishing such a floridly negative result. The pediatricians took their name off the paper in order to really expedite the publication of this paper, and I think that folks like Phil Sunshine certainly belonged on that paper, but for reasons that we'll not discuss, that really were selfless, were wholly selfless, did not appear on that authorial list. But it's emblematic of the kind of culture that existed for the advancement of knowledge. This paper is still powerful. It's influential, more than 2,000 citations. There were 94 in 2017. There were 5 when I checked in 2019 last night. It was really a tribute to deep phenotyping where people knew exactly what went on with each baby, and it was very transdisciplinary, as most great works are. There were a number of other landmark occurrences that got us to where we are today. Perhaps one of the most significant was this paper from New Zealand in 1972. Liggins and Howie published in Pediatrics that this randomized trial of 230-some infants that demonstrated that antenatal glucocorticoid treatment prevented neonatal respiratory distress syndrome. 1972, Drs. King and Clements identified the surface active materials that were in surfactant, and this really paved the way for surfactant replacement therapy, much of which happened across the United States, but also leading edge was in Japan. And it's fitting, too, that here we are in Berg Hall and recognizing that Paul Berg, who created the first recombinant DNA molecules, which really motivated a huge percentage of what has come since that time. Dr. Nogi's seminal paper in 1993 in the New England Journal. And as Dr. Clements says, every time scientists are forced to look outside their disciplines, cross-fertilization can happen. So as we move on today, I want to call out a quote from Dr. Whitsitt's recent paper that was in Nature Communications, saying that elucidation of the diversity of pulmonary cells and cell-cell interaction provides the means to understand the pathogenesis of lung diseases affecting newborn infants. This is really where we've really learned how to read quite well the genomics of each individual cell, and that permits us a level of resolution that we never had before. So some of the critical questions that we're going to ask today in each one of these sections, I hope. We're going to talk about neonatology and the genesis and the genetics, and I think it's important to understand how we got here. We're going to talk about how we can move the needle in CDH. We're going to talk about childhood lung diseases and if there's a common thread and can it be exploited. And we're going to really try to phenotype BPD a little bit more carefully. Should we lump? Should we split? Can we prevent? Can we cure? And I want people to think about the question through the day that now that we can read the genome so well, are we ready to write? Are we ready to edit? And if we are able to scientifically, should we begin on the editing process, which inevitably is coming? I want to end with one thought that was recently published in the New England Journal. And this was an article that Lisa Rosenbaum wrote in commentary to actually a review piece that Matt Porteous, one of our faculty members, wrote on gene editing. And Lisa Rosenbaum wrote about some of the ethical conundrums of gene editing, and she quoted a friend of mine who's a UCSF cardiologist, Ethan Weiss, and she said that prospective parents may find their choices difficult when considering the implications of gene editing or how we actually manipulate our genomes. Ethan Weiss, a cardiologist and scientist at UCSF, is a father of Ruthie. She's a 12-year-old young lady with albinism, and she is legally blind, but she's an outstanding basketball player. She's a great skier, and she's an inspiration to all around her. Yet Ethan said in this article, and he said it for public attribution, had he and his wife used pre-implantation genetic diagnosis, they would have chosen an embryo without the mutation. And Ethan says, that's what terrifies me. Not just that the family would never have experienced Ruthie's magical influence, but that as a society, we will marginalize difference even more. So as we move forward through the course of the day, let's think about what it is we need to do to cure, and let's think about what it is we ought to do to move forward with eyes wide open and with great insight as we bring the tools that our science is allowing us to use to children and infant lung disease. So with that as introduction, I'd like to introduce my friend and colleague and mentor. Well, before I do that, I'm going to introduce Dr. Bennett, who is going to introduce the next session. And he is my friend and collaborator, and in many ways a mentor.